are covered in your textbook in chapters 17, 30, and 43. I would not recommend spending a great deal of time on chapter 30 as it is duplicative of a lot of material already covered in chapter 17. So for the purposes of studying for the exam, it would be important to focus on the slides. The drugs to treat respiratory disorders are in several classes. We have the bronchodilators, which is broken down into three subsets: the beta agonists, the xanthines derivatives, and the anticholinergics. Then we focus on drugs which suppress inflammation. These include indirectly the mast cell stabilizers, inhaled corticosteroids, leukotriene modifiers or inhibitors, and phosphodiesterase 4 or PDE4 inhibitors. While asthma and COPD have similar symptoms, they have very different etiological pathways and prognoses. Asthma is a disease of inflammation. It is largely related to having an allergic predisposition. The patient comes in contact with substances which trigger the bronchospasm. Treatment can be disease modifying in asthma. That is to say, that treatment can prevent permanent remodeling or stiffening and thickening of the bronchial tree. So adequate treatment is important not only to treat current day symptoms, but to prevent long-term changing from asthma to a more fixed obstruction situation down the road. Drug therapy, however, provides symptomatic relief only in COPD. It has no disease-modifying effects, but it does help to control daily symptoms. In COPD, the trigger for the development of the disease is the inhalation of toxic chemicals, including those found in cigarette smoke and those found in air pollution. So although the same drugs are used in treatment, the responses of asthma and COPD to pharmacotherapy differ. Adrenergic agonist bronchodilators. These are sympathomimetics, that is to say they trigger the action of the sympathetic nervous system, and this results in smooth muscle relaxation. Non-selective beta-2 adrenergic receptor agonists, and to a lesser degree selective beta-2 adrenergic agonists, also have effects in other parts of the body, and they cause reflex tachycardia. Beta-2 selective agents have the greatest effect on bronchial, uterine, and vascular smooth muscles. When given by the inhaled route, very little of the beta agonist reaches the systemic circulation. Therefore, there are very few real contraindications to their use, the tachyarrhythmias and narrow-angle glaucoma being largely the contraindications. Recent evidence of an increase in cardiac events in the first 6 weeks of new use of a beta agonist by a person with existing coronary artery disease or heart disease has popped up in the literature. And while that's of note, it is not a reason not to use the beta agonist for relief of symptoms. Beta agonists also affect pancreatic beta cells and increase insulin secretion at the same time as they increase glucagon and glycogenolysis. So they can have effects that are significant in someone who has brittle diabetes, or in an insulin-dependent person. They can make their diabetes a little bit more brittle in terms of hypoglycemia. The action of beta agonists. Beta-adrenergic receptors are coupled to a stimulatory G protein, adenyl cyclase. This enzyme produces a conversion of adenosine triphosphate, or ATP, to cyclic adenosine monophosphate, CAMP. In the lungs, CAMP produces bronchodilation, or smooth muscle relaxation, and inhibits the release of pro-inflammatory substances, and these are both desirable effects in someone with asthma or COPD. The short-acting beta agonists referred to as SABAs, include albuterol and levoalbuterol, among others. But albuterol is probably the prototype in this class of drugs. Brand names are Ventolin or Proventil, also among others now. The meter dose inhaler delivers 90 micrograms per actuation, and it's an inhalation aerosol or powder. It's 2 inhalations every 4 to 6 hours is needed. Additional inhalations may be needed, but patients should promptly consult their PCP if they have a sudden increase in their need for using the inhaler, and they should not exceed a maximum of 8 doses per day. This medication is also available in a nebulization solution for use in a handheld nebulizer, and that dose is 2.5 milligrams 3 to 4 times daily as needed. Has a pediatric indication for in the metered dose inhalers. It can be used with a spacer in children above age 4 or older, 1 to 2 puffs Q4 to 6 hours. For children 2 or over, it can be used in a handheld nebulizer, and it's 1 3 milliliter unit dose vial of 1.2 milligrams or 0.6 milligrams inhalation solution, and that dosage is based on weight. Levoalbuterol, or Zopanex, is a meter dose inhaler, 2 inhalations, 90 micrograms, Q4 to 6 hours as needed. In some patients, they can get by with 1 inhalation every 4 hours, but the maximum dose is 2 inhalations every 4 hours in children greater than 4 years old to adults. The solution for nebulization, the initial dose is 0.63 milligrams 3 times daily at intervals of 6 to 8 hours while awake. The dosage may be increased to 1.25 milligrams 3 times daily, but you have to watch more closely for the adverse effects, which would all be the sympathomimetic effects of tachycardia, excitability, increase in blood pressure. The pediatric use for this drug is off-label in children less than 4 years old, but doses of 0.31 to 6.63 milligrams Q6 to 8 hours have been well tolerated.